I'd like to welcome everybody to the Iowa State Dairy Goat webinar. I'd like to remind folks to be muted during the program and to open up their chat box during the presentation and put their questions there. We will allow time after the presentation to go ahead and try to get all the questions answered. Our presenter for today is Dr. Paul Plummer. He's a professor at Iowa State College of Veterinary Medicine. Probably needs no introduction to our dairy goat industry in the country and around the world. As I always say, Dr. Plummer, the podium is yours.
All right. Well, I appreciate the opportunity to visit with everyone today. I see some familiar names on the Zoom, so excited to see you here and participating, and excited that we were able to get this on the books. It's hard. I travel a lot these days, and so in town for 2 or 3 days, and so we were able to get this on the books and visit with you. Today, the topic we're going to talk about is neonatal diarrhea in goat kids, and certainly more focused on dairy goat kids in the context of this webinar. And I'm hoping that through this process, we're going to be able to come out with some practical strategies for managing and responding to neonatal diarrhea. Certainly, it's an issue that we see more frequently than we would like, and one that can be really problematic on some of our operations, and so it's one that often we think about a lot of different interventions, but sometimes good old management is really the important part here. And so hopefully through the next couple of slides and everything, we can really start to come up with some practical strategies here to manage neonatal diarrhea. And so just kind of from an overview perspective, my intention here is we'll start off with a little bit about what does neonate mean. That's really important in the context here of the pathogens that we're going to be talking about, and what pathogens are in that list, and what pathogens should not be. We're going to spend a reasonable amount of time talking about the balance of pathogen load versus immunity. And this is a concept, there's not hard and fast numbers in any of this, but I firmly believe that a good understanding of this can go a long ways towards understanding the dynamics of neonatal diarrhea in our operations and how we manage those. So we'll spend a little bit of time talking about that. We're going to cover some of the common pathogens. I am not going to dive deep on those common pathogens. When we get there, I will provide some pathogen-specific input, but I also believe that while diagnostics are important, we'll talk about diagnostics. Many cases, the management changes that we need to make to address some of these issues are the same regardless of the pathogen. And so I'm always encouraging the students to not get so hung up on the pathogen that we miss kind of making the broader, more general changes that often are helpful. So after we talk a little bit about diagnostic approaches, then we'll finish up with management and a bit on treatment, and so that's kind of where we're heading. So on this first topic, what do we mean by neonatal? When we talk about neonatal, we're talking neonate refers to being associated with the first few weeks of life. And so for today, we're really talking about kids that are less than 10 to 14 days of age. And so that first 1 to 2 weeks of age is our focus here. And as I mentioned, that's important because that eliminates some of the pathogens that often people have come to mind when they think about diarrhea in goats. And so by confining to this first couple of weeks of life, it provides us several advantages. Number one, the pathogens are a little bit different than when we get later and weaning and into even adults. But our management strategies also can be different, and our prevention approaches are different. And so yet nonetheless, this neonatal period is when we see a lot of disease and when we have a lot of morbidity and mortality. And so it's really an important focus on our dairy goat operations. So I mentioned that, to me, the basis of almost all of this is the balance of antibody levels or immunity balanced with pathogen load. And so you can see I've kind of drawn a teeter-totter here. And on one hand, on the left, we have the immunity. And I think everybody on the call probably remembers. If not, remind you that these kids are born essentially without passive immunity. And so the antibodies, when they're born, they have no antibodies to ward off these pathogens. And so either their moms, their dams, or in the case of many dairy goat operations, us as the producer or the operator are the ones that take on the responsibility of getting that antibody into them. And we can do that through several different ways. We're going to, kind of touch on this topic of colostrum management, but I know that there's been other webinars on colostrum management, and those are available. So I'm not going to deep dive on that. But recognize that this left-hand side of the teeter-totter is on us to determine how well. They start with 0. And so whether it's through raw colostrum that we're feeding them, heat-treated colostrum replacer, whatever we're doing, the concentration that we get over on that left-hand side, or the total amount that we get on that left-hand side, is driven by our management practices, particularly if we're separating at birth. And I should point out that it's not even just how we manage the kid, because how we manage mom and can also impact that. So if a doe does not, pardon me? Oh, I thought somebody was talking. If a doe milks through, or we fail to dry her off, and so she freshens and we have no colostrum, then that's not just how we get it to the kid, but it's an impact of how we're managing mom as well. Likewise, on the right-hand side, we see that pathogen load. And for the purposes of today, we want to think about being the number of the bacteria or viruses that the kid is exposed to. And so certainly a lot of that is management. How are we housing these animals? How are we commingling them? How are we protecting them from those high pathogen loads? What is the cleanliness and hygiene of our feeding systems, of our pens? To some degree, what is the ambient weather? Is it wet and humid, and or is it minus 20 and snowing? And so these pathogen loads can have a lot of different characteristics or attributes that impact them. But again, it ultimately gets back to a management strategy. So in terms of environmental conditions, we have some control over that from a management strategy. In terms of how the feeding equipment is handled and cleaned, we have some control over that. In terms of how frequently those pens are getting cleaned out, or how heavily stocked and the stocking density of those pens, we have control over that. So again, drawing us back to this balance, we have immunity on one side, we have pathogen load on the other. All of our neonatal diarrhea outbreaks essentially are a loss of balance here. And so from a management perspective, we're the way I approach these is looking for what has caused us to lose balance there. And it can be on either side. But the good news is that sometimes, if we increase immunity, then that actually can balance with a higher pathogen load, or vice versa. If we're having problems getting enough immunity into them, if we pull down our pathogen load, we can restore that balance. And so I think by the end of this presentation, sure, we're going to talk about treatment, but we're going to talk a lot more about prevention, and we're going to talk about management. And to me, neonatal diarrhea is really a management issue of managing immunity to pathogen load. So with that as a background, what are our common um, causes of neonatal diarrhea? And we'll dive into this here a little bit more in the next slide. But as I mentioned previously, neonatal diarrhea is a common cause of illness and death in dairy goat kids. And we really see, the most commonly two viruses, two bacteria, and a protozoan that we routinely think about. And so I've put those on the next slide here. And as I mentioned, there's not a ton of technical information on here. I'm going to verbally give some more technical information. We've got a wide variety of folks in the audience. So we've got some of you all are veterinarians, have a lot of this expertise. Some of you are producers with expertise. Some of you are 4-Hers with just learning in this process. So to keep the slides understandable, I've left them at a fairly high level, but we'll dive into those a little bit more in the presentation as we talk through each of these. So I mentioned two bacteria. The most frequent bacteria that we see, at least in our area, are E. coli and Salmonella, the top and the bottom on this list here. We do tend to see some corona and rotaviruses. So those are the viruses, the two viruses I mentioned. And yes, that coronavirus, it's not SARS-CoV-2, but it is in the same family as SARS-CoV-2. So these are the same sorts of coronaviruses that we've all kind of had to deal with over the last couple of years. And then I mentioned a protozoa, a cryptosporidium there. I've put just some very high level take home points next to each of these. And I've tried to keep that at a high level so that hopefully I can drive home that I think there's some of the most important outcomes. Certainly, each of these organisms has a complex life cycle. There's all kinds of things that we can dive into molecularly and related to antimicrobial resistance, and all kinds of opportunities to dive deeper on these if you have questions. But at a high level, just a couple of notes that I want you to remember. And so in the first one, the E. coli, so this is Escherichia coli, a bacterial organism. And this is the first one that we see. And so this is the one that has the potential to cause diarrhea very early in life. And in fact, for me, if I'm seeing significant diarrhea at a population level, before a couple of days of age, certainly before 3 days of age, and sometimes within 24 hours in extreme circumstances, it's going to be E. coli until I prove it otherwise. E. coli is my working diagnosis in those really early episodes. Now, there's some characteristic odor to it, a little bit of a characteristic appearance, and so as you're exposed to more of these, and have perhaps experienced this, that also helps with the diagnosis. But when a farm calls and tells me that they're starting their neonatal diarrhea outbreaks, and they've got kids at less than a day or less than 2 days that are breaking consistently with diarrhea, E. coli is where my mind's going, and we're going to be heading down that path. Corona and rotaviruses, certainly we can see in this neonatal period, but they take a little bit longer onset. And so a lot of times we're not seeing those until later in the first week into the potential second week. And so I don't want to discount them at all. But I will also say that many times when we have a rota or a coronavirus issue, we actually have concurrent others. So we quite frequently will see it like an E. coli and a corona, or E. coli and a rota. And so once those E. coli set in early and start knocking down immunity, utilizing those antibodies, then some of these other organisms, that balance of pathogen to immunity starts getting thrown out of whack, and you can have some secondary pathogens coming in and causing problems. Cryptosporidium, we certainly can see early, and it is a protozoa, as I mentioned. But the big take home here for me is that this is an organism that aerosols very easily, and so this is highly contagious. I don't have to just be concerned about the local environment where those kids are being housed, but I have to be concerned about the airspace as well. And so we'll talk a little bit about that, but this is one that is zoonotic to humans, so that means humans can become infected with Cryptosporidium by aerosol. And so when we start thinking about management strategies and stuff, if we have a Cryptosporidium going through, this is not a scenario where we want to be, even though we want good hygiene, this is not a scenario where we want to be using pressure washers and those types of things, because those will aerosolize that Cryptosporidium, and then you inhale it, other animals in the environment inhale it, and you can actually have transmission by that route. And so this is an organism that, because it's a protozoan, is not going to be responsive to antibiotics. And because it's aerosolized, we have to think about other management strategies to mitigate this. And then the one that I have down here on the bottom, Salmonella. Certainly we do see Salmonella in some of these neonatal goats. But in my experience and in our practice here, I don't see Salmonella in the absence of illness in other animals in the herd. So it's extremely rare to have a neonatal diarrhea driven by Salmonella that's purely causing problems in those neonates. Typically, we're having some issues in some other animals, other age classes of animals on the farm. In many cases, sometimes the dams are sick or having problems. And so this is one that needs to be on our differential list. But often if the issue is purely confined to the neonatal kids, it's going to move a little bit lower on my list until I have some diagnostics that are really driving me down that path. So again, E. coli, corona, rota, crypto, and salmonella are our top 5 when we're talking about neonatal diarrheas. I mentioned some of these are zoonotic, so we want to have good hygiene, good hand hygiene for ourselves, and good, kind of cleanliness, changing our clothes when we come in from the barn, handling these kids, and having dedicated barn wear that's different from, what we're wearing in the house. Washing our hands before we come in. Certainly, some of these organisms can move into our living environments on our clothing or on our hands, and that's a potential risk for infection. I mentioned to be cautious with pressure washing, particularly if Cryptosporidium is a consideration in this process. And most importantly, what I want to point out that's not on that list on the previous slide is coccidia or intestinal worms. And so now coccidia is a significant driver of diarrhea in goats, and it's a significant driver of diarrhea in goat kids, but not in this neonatal period. So in this first week to 2 of life, the life cycle of coccidia is such that it is not going to be able to cause clinical disease that early in life. And so while once we hit week 3, and certainly out around stressors around weaning time or weather changes, as these animals are moving off of weaning late on milk or moving into the weaned pen, grower pen, coccidia is a huge and important issue there. What we're talking about today is not going to focus on that at all, because that's not in this neonatal period. And so that's important, because it's quite frequent that when I talk to folks, they're experiencing a neonatal diarrhea, even at a week of age, they'll be like, okay, we went through with some amprolium, or we went through with, or they're on a creep with some decox in it. All of those are potential, beneficial things as we start to get a little bit further out. But I can tell you in week 1, it's not a coccidia. We don't have to be worrying about those, treating for coccidia as the cause of the diarrhea in these early ones. And the intestinal worms is the same scenario. So by confining it and really looking at these first 2 weeks, that allows us to take these off the list. Now, once we get out to weaning, or even 4, 5, 6 weeks of age before we've weaned, coccidia becomes our number one. And so we really have to be concerned about coccidia stats, control, cleanliness, hygiene, still an important issue. Immunity versus pathogen load is still all important there. But in these newborns, coccidia is not driving that process. So when we think about diagnostics, as I mentioned, diagnostics are important, and certainly as a veterinarian, I want to pursue these diagnostics. I see value in them, and you know, they can help me in this process. But what they really actually are doing more for me is helping me to think about what potential additional prevention measures I can put in place for next year to help prevent disease. Are there opportunities to use some vaccine or something to assist with this? But they're generally not driving what I'm intervening in at the moment. So when I'm in the middle of that outbreak, in many cases, I'm making changes based on not knowing the pathogen or the diagnostics, or a presumptive diagnosis of the pathogen purely based on clinical presentation. So we still need to be running our diagnostics, but this is not a scenario where we need to sit back and wait on our diagnostic testing to make changes, because we can implement those much earlier. So in terms of diagnostics, we're going to typically submit some feces, some diarrhea from these kids for a culture, a bacterial culture, to the diagnostic lab. I'm most frequently there looking for E. coli. We could also obviously pick up a salmonella if we've got some selective media, appropriate media for doing that, which would often be the case. But E. coli is often driving that process, particularly, again, if I don't have systemic disease in a number of other animals in the herd. But that E. coli culture is important. We'll talk next about PCR, but I'm going to point out that the PCR that we currently offer is somewhat limited in what E. coli it'll pick up. And I can tell you from experience in these dairy goat operations, in many cases, we're picking up E. coli's that aren't necessarily picked up by that PCR diagnostic. And so culture is important here, along with the PCR diagnostic. The second item down there is a multiplex PCR. We have one of those focused on neonatal diarrhea here at ISU. Some other diagnostic labs have those as well. Now, almost all of those are focused on ruminants. So they're ruminant neonatal diarrhea diagnostics. They're not specific to goats or sheep. And so that does bring into that equation a bit of a, some caveats. So Rota and Corona, so this diagnostic includes all 5 of our big ones that we talked about: Rota, Corona, E. coli, although it's only the K99 E. coli's, Salmonella, and Cryptosporidium. All of those are our major drivers of diarrhea, so that's very helpful. One PCR gives us all of those. But again, as I mentioned earlier, sometimes we see E. coli's that are not K99s. K99s drive disease in some of our other livestock species, and so that's why they're focused on here in this particular PCR diagnostic, is that in the broader, the mass number of these tests that we run, having that focus is beneficial. But we have to be careful when we don't get an E. coli positive on this PCR in a dairy goat, that we don't eliminate E. coli as a possibility, because we can have those non-K99s. And that's where our bacterial culture gives us some benefit. The Rota and Corona are optimized for bovine isolates. There are cross-reactivity to goats and sheep isolates, and we definitely see goat and sheep positives to these Rota and Coronas. So if I see a positive to Rota or Corona, I believe that that's important, and I'm interested in that. But if they're negative, I can't completely eliminate it off the list as a possibility. And then the salmonella and the crypto have good sensitivity and help us pick up. So when we run this diagnostic, we can run this on feces. Again, it gives us one test. It's a fairly quick turnaround, and we get back a result for each of these 5. We get back what's called a CT value, or a number, and the lower the number, kind of somewhat counterintuitively, if you don't understand how quantitative PCR works, the lower the number, the more pathogen there is there, the less cycling it took to get a positive. And so, what I also want to point out is that it's not uncommon for this diagnostic to tell us that there's 2 or sometimes even 3 of these organisms that are present in a sample. And so, that can be a bit disheartening at times, but it just gets back to that this management is so key. And so the good news there is that typically when we start thinking back to how are you managing immunity and pathogen load, we can respond even though we might have 2 different or 3 different organisms here. We can make a similar response. Whereas if your response, you're really wanting to kind of try and focus on what antibiotic can I use, then that's a lot more problematic when you have multiple pathogens involved. So we'll continue to talk about those treatment options, but in terms of diagnostics, I just want to drive home typically culture and a multiplex PCR is my preference, interpreting those. But again, even in the absence of these, we can make management changes that often help us to address these issues. We're going to transition now for a few minutes about treatment, and then we'll finish up with some management stuff. But as we think about treatment, there's really 2 primary things that we need to rapidly assess in these kids. And obviously, this is going to be a bit different if we're talking about managing a neonatal diarrhea outbreak in a larger operation where we got 300 kids versus a smaller backyard herd where perhaps you're only dealing with 2 or 3 kids. But what really drives morbidity and mortality, what really drives illness and death, is not the pathogen itself in many cases. In some, it is driving that. But the more frequent issue is either dehydration or the acid-base status. And this is a blood acid-base status. So these are where we need to be focusing our treatment efforts on. We will talk about here in a minute more targeted like antimicrobial therapy treatments, but realize that antibiotics in the absence of addressing dehydration or acid-base status often do nothing. And in reality, very few of our animals actually need antibiotics to be successfully treated. So fluid therapy, managing the hydration status, and this blood acid-base status are where our focus needs to be on treatment. So when we talk about this acid-base status, we really are talking about the pH of the blood. And in normal, healthy animals, that pH is held in a very tight range, about 7.4 for most mammals. And so that pH, the body's physiologic mechanisms have ways to balance out acids and bases that we intake. And we intake all of these. So, if you think about our diet as a human, we drink everything from orange juice, which has a very low pH of 2 or 3, sometimes up to, baking soda that has a very alkaline pH. And so like that, these kids are consuming different things in their environment, and the bacteria and protozoa in their GI systems are producing chemicals that they can absorb that all impact this acid-base status of the blood. And when we look at neonatal diarrhea, our primary issue is that it typically causes what we call a blood acidosis or an acidemia. the blood's pH goes down below what it should be. And that has significant physiologic consequences that we see manifest as the illness. That's what drives these kids or calves, whatever ruminant we're talking about, ultimately becoming recumbent, losing their suckle reflex. And so it's that acidosis that's driving a lot of that. Acidosis can occur in the absence of diarrhea, and we're going to talk about a specific scenario here in a couple of slides briefly called floppy kid syndrome, which is by definition blood acidosis in the absence of diarrhea in goat kids. And so I think that when you think about it, if you've ever had a floppy kid syndrome in your herd, that starts to drive home the role that this acidosis plays, that this is what's really making a lot of these kids losing them because they can't nurse, they can't stand. And it's not necessarily because they have diarrhea or a pathogen. Yet when they get diarrhea, they're getting this same process. So the neonatal diarrhea organisms often also induce this acidosis, and that's what's driving our clinical manifestation. So this is traditionally, we've associated this with bicarbonate loss. So bicarb is an alkaline, high pH, and as diarrhea occurs, that bicarb sometimes comes out in the feces. We have changes in the kidneys management. That's what this GFR is. Kidneys change their management of acid-base status. And then we have some of these unmeasured anions, which are products that are produced by the bacteria and GI organisms that then can go into the bloodstream. And I want to briefly talk about one of those because this is really important in the context of some of these pathogenic neonatal diarrhea organisms. And that's that these bacteria produce what's called D-lactic acid. And D-lactic acid is different from lactic acid that we produce in humans. So if any of you are runners or you know a runner or you've been in the hospital, sometimes we run lactate levels. And I talk about runners because when we anaerobically use a lot of energy, we often produce as a byproduct lactic acid, and that lactic acid is what drives muscle cramps, and some of the changes in the body can actually change the blood pH as well. And so those similar types of things can happen in our ruminants, but in general, they're not running enough to get a lactic acidosis. However, the bacteria produce lactic acid, and this lactic acid that the bacteria produce is a D-lactic acid, which even though it's kind of like, well, it's just a letter D instead of L lactic acid. But this is how the lactic acid is structured, and it is unique to bacteria. So even though those kids have mechanisms, just like we as humans have mechanisms to manage lactic acidosis that's produced L-lactate, none of these, we nor the kids, have the ability to metabolize D-lactate. And so this D-lactate is produced by these bacteria. It gets into the bloodstream. It changes the pH of the bloodstream, drops that pH, and then that causes these changes in physiologic function that we talked about, where they're unable to stand, they're unable to suckle, and all of those clinical signs that we associate with the diarrhea. The diarrhea might be driving fluid loss, might be driving dehydration, and it can impact blood gas itself, but sometimes it's actually this D-lactate that's causing that. And as I mentioned, floppy kid syndrome is exactly this type of scenario. So we can see D-lactic acidosis in kids with diarrhea or we can see D-lactic acidosis in kids in the absence of dehydration and diarrhea. And in those scenarios, we call that floppy kid syndrome. They tend to be a little bit older in age, but they become completely flaccid and lose their suckle, but they respond generally quite effectively to bicarb therapy because we're raising that blood pH. I know this is all fairly technical, but my goal with spending a bit of time talking about it is just really trying to drive home to you how important this blood acid base issue is. And that, if we're not dealing with treating that blood acid base issue, in many cases, we're not going to have a successful treatment outcome for those animals. And so I want to make clear that that's the case. Certainly, they're also dehydrated, and so we need to manage that. So when we think about dehydration and we think about acid-base status, the way we fix that is with fluid therapy. Now, that can be IV fluid therapy that we give in the vein, or it could be potentially oral fluid therapy that they either suckle, nurse off of a bottle, or that we tube into their stomach. But fluid therapy is critically important and should be the first component of intervention on these kids if our goal is to save them. Now, some of these animals, when we find them, they're going to be significantly sick enough that humane euthanasia needs to be a consideration. And so that certainly, may be necessity. But when we're trying to intervene and save these kids, and we feel like we can effectively do that, fluid therapy, either oral or IV, needs to be part of that process. These are not going to respond generally to just going out and giving a dose of some vitamins and some antibiotics. Because again, even if the antibiotics are effective at killing the bacteria, then if they still got an acid base issue or they're dehydrated, the antibiotics don't fix those issues. Likewise, if it's a viral organism, antibiotics aren't going to do anything, or the protozoa, crypto, the antibiotics that we typically use aren't going to do anything there. So fluid therapy is critically important. We need to replace the volume deficit. If they're dehydrated, we need to correct the dehydration. For the vets in the audience, this is just like any sort of volume replacement. Calculate the percent body weight times the percent or the percent dehydration times the body weight. That's going to allow us to calculate our volume that we need to replace in those animals. And then we can decide, are we going to do that with oral electrolyte therapy, or are we going to do that with IV therapy? We need to be thinking about correcting the electrolyte abnormalities. And so, we are going to have had loss of sodium. We're going to have had loss of potassium, and we're going to have had loss of bicarbonate. And so in our fluid therapy, whether we're giving oral electrolytes or we're giving IV electrolytes, we need to be thinking about that with the goal of correcting this acid-base status. And really, those electrolytes are what's going to help to provide us the mechanism to correct that blood pH. And then we need to be providing energy. It used to be when, back when I was growing up in the industry and in dairy cattle industry as well, when we talk about diarrhea neonates, many cases we would pull those animals off of milk and then implement fluid therapy. So we might do oral electrolytes or something, but we would actually pull them off of milk for a period of time to try and get the stool to firm up and everything. And we now realize that that was a really bad plan, because in this illness, the energy demands of these kids actually goes up. And so they require more energy than when they're healthy, being sick. And so by pulling them off of ample, adequate energy, we're just actually causing them to be weaker and to go downhill. And so current recommendations are that we maintain good nutrition during this period of therapy. Now, we may have to work around how we administer our therapy based on how we're doing nutrition there, but we don't want to be pulling these animals off of milk entirely. That said, we also don't want to be tube feeding them milk And if they can't hold their head up and they're laying in lateral recumbency and that milk just runs right back up their esophagus and they aspirate on it, that's not a good scenario either. So in those cases, we need to be addressing the acid-base status of those animals so they can sit upright and at least hold themselves upright, not be out in lateral recumbency, so that if we're administering, tubing them with milk or they're nursing, that's not just refluxing back up and causing aspiration. So how do we decide if we're going to do oral electrolytes or IV fluid therapy? These are just some thumb rules. Oral, if they're able to stand and they're strong, so they've got diarrhea, but they're still up, they're standing, they're less than 8% dehydrated, and so their eyes aren't real sunk in their eyeballs. They're losing some fluid, no doubt about that, but they're not dehydrated to the point that they're turning into, little grape type of deal. And they have a strong suckle reflex. And so we'd like to see that suckle reflex if we're going to give it to them orally, just so that when they nurse, they're not aspirating that. In the absence of that, then we may need to be thinking if they're not able to stand and they're not strong enough to stand, or they're over 8% dehydrated, or they don't have a suckle reflex, we need to be considering IV fluid therapy for those animals or euthanasia if we're not prepared to pursue IV fluid therapy with those. So just a little bit here on oral fluids. I think the key take home here is, there's this technical component. So we want sufficient sodium in there to replace extracellular fluid volume. We want agents. Sodium doesn't just get absorbed. It has to be co-absorbed. And so we need some stuff in there to help sodium absorption. We need to alkalize them. So we need to address this acid-base status. We need energy. But the key take home here is I want to make sure that people recognize when we talk about oral electrolyte fluids for these kids, we are talking about dedicated neonatal diarrhea electrolyte therapies. They can be the same ones, and they typically are the ones that we would use on dairy calves or even beef calves with neonatal diarrhea. This is not electrolytes like we might administer to an adult animal or to, some of you show, and, there's all these blue light or all these different things that are great products for replacing electrolytes in adult animals. But that's a very different physiologic process than these neonates. And so we are talking about an oral electrolyte fluid plan here that is designed specifically for acidotic neonatal diarrhea or acidotic neonates. So you just want to be careful when you work with your veterinarian, or if you are a veterinarian and you're ordering product, that you're picking something in this space. There's all kinds of ones on the market. I'm not going to get into naming any particular name brands or anything like that, but just make sure you're picking a neonatal electrolyte fluid therapy and not an adult fluid therapy, because in fact, in some cases, those adult fluid therapies would be contraindicated because of the differences in electrolyte composition here. So I'm not going to spend a lot of time on this. We want those sodiums, though, to be high. But the fact of the matter is, all of this technical detail, if you are purchasing one of the well-established, more recently formulated electrolytes for neonatal diarrhea, they're going to have these types of characteristics. So we do want to make sure that they have an alkalizing product in them, though. And there's several options there. Those are bicarb, acetate, or propionate. The benefit of acetate and propionate, those are my preferred option for oral. And so, number one, they facilitate sodium absorption. And we briefly talked about that sodium absorption is really important because that helps rehydrate them. But it requires some additional, electrolytes or compounds to help with that uptake. And so acetate and propionate do that. When they're metabolized by the liver, acetate and propionate actually produce energy. So we talked about energy was being important. And so they produce some energy. But perhaps most importantly, acetate and propionate don't have as significant of an impact on alkalizing or raising the pH of the abomasum. And that pH of the abomasum is critically important in how these kids are metabolizing the milk that they consume. So that abomasum is extremely acidic environment. And when the milk goes into the abomasum, it actually forms a milk clot. That milk clotting process is important to digestion. Maybe not quite. We used to think without that, you were just totally toast. It's not quite that important, but I think we do still believe that there's enough value in that normal process that, we like to see it occur. But it's driven predominantly by the pH of the abomasum. And so if we use oral bicarb, then that changes the pH of the abomasum, and we don't get as good a milk clot, and we may not be as effective in nutrient absorption from the milk that they're consuming. Acetate and propionate don't change that abomasal pH. And so we can administer those products even with some milk in the system, in the GI system, and not have as big an impact on normal milk metabolism as we would if we were using something like a sodium bicarbonate or a baking soda. So I prefer to identify these oral electrolyte fluids that have an acetate or a propionate as my alkalizing agent as opposed to bicarb. So we're going to administer these orally, obviously. My preference is for them to be suckled. And we talked about, a strong suckle reflex is ideal if we're using oral fluids. If they're upright and they're standing and they can maintain posture, we could consider tubing these as well. And we certainly will do that in some cases. But we talked about this importance of milk clotting. And so particularly if we're using a product that has bicarbonate in it, our preference would not be to administer the milk and the electrolytes at the exact same time. And particularly, we don't want to mix the electrolyte powder up with milk. Those are designed to be separate from each other. They're designed to be mixed in water. There's other electrolytes in milk. And so if we try and mix up electrolyte powders, not all of these products come as a powder, but some of them do come as a powder. But mixing them up with milk and trying to, proverbially kill two birds with one stone with, instead of mixing this electrolyte powder up with water, I'm going to use milk, actually defeats the process. So we don't want to mix it with milk. And ideally, we'd like to have an hour or two between milk administration, which again is still important. Don't pull them off milk, but, not have our electrolytes right at that same time. Now, if they're over 8% dehydrated or they're unable to stand, they've lost their suckle reflex, they have severe CNS depression or weakness, they're not responsive, they're comatose, then we definitely need to be moving into IV fluids or considering humane euthanasia if we're not going to treat aggressively. This is also a scenario where if we start to see, they haven't suckled for more than 24 hours, or if we're getting extremes in temperatures, really low temperatures or really high temperatures, that these would be body temperatures, so less than 100 Fahrenheit. So this is a kid that's losing its thermoregulatory ability and becoming cold. Then as they lose that thermoregulatory ability, the blood in the how the body distributes blood changes, and we see changes to blood flow to the GI system. And so even though we might be putting fluids in the GI system, when those kids are that cold physiologically, they don't absorb those fluids, and so they're not giving us the benefit we need. So if we have these kids that have lost their ability to have a normal body temperature, that's generally not a very good prognosis in general, but we need to be thinking about a more aggressive IV fluid therapy plan than we would be on the ones that are normal temperature and able to stand. I'm not going to spend a lot of time on this because this is really something that's a little bit more complex, and probably something that you would have your vet help you with. But for the vets on the audience, I did just want to point out that as we think about IV fluid therapy here, ideally we're running that, driving that off of a blood gas analysis or an anion gap. That's not always feasible, and so sometimes we have to make those decisions without that. But in theory, we can calculate exactly how much bicarb we need to replace in these animals, and that definition or that calculation is here. I will tell you from a practical standpoint, these are often the starting points for where we need to start. And so they're going to continue to lose bicarb. So it's not, I calculate this out, I replace that bicarb and I'm done, because they're going to continue to lose it. And so we're going to have to continue to administer it. But these are a good starting spot. There are scenarios where we can have non-acidotic neonates, and if we get real aggressive with these therapies, we might drive them alkalotic. And so that's why there is value in trying to assess, is this animal really acidotic before we get aggressive with IV alkalizing agents. Now, a small amount of IV alkalizing agent and assessing improvement certainly can be a reasonable plan, but we can over alkalize animals, and that has its own whole set of problems that we want to try and avoid. And so again, for the vets in the audience, this is just a reminder specifically that 13 grams of sodium bicarb, so 13 grams of sodium bicarb in 1 liter of distilled water or 1 liter of sterile water is going to make an isotonic sodium bicarb solution that you could then use for IV administration, and it has 155 milliequivalents per liter. So we can make these bicarb solutions ourselves. You can buy hypertonic bicarb, but if we're using sterile water or distilled water and baking soda, we can make these and administer them once we've calculated what the appropriate dose is going to be. All right. So I talked a lot about fluid therapy, and my talk about antibiotics is going to be shorter. So most of these kids don't need antibiotics. Yeah, that's almost where we see everybody wanting to go, is to antibiotics. The use of when we use antibiotics and they're not needed, that results in disruption of the normal bacteria in the intestine, and that can cause diarrhea in its own right. It can also cause more residual changes in nutrition. And then when we use antibiotics and we don't need them, it also increases antimicrobial resistance. And so, as we use those antibiotics, then the bacteria develop resistance to them, and then they don't work when we do need them. Whether that's a need that's related to a sick diarrhea kid that really does need them, or many of these kids also have respiratory pathogens in their upper airway and stuff. And so sometimes I've seen situations where farms have aggressively used antibiotics to try and either prevent or treat neonatal diarrheas, and then they get respiratory outbreaks, and none of the antibiotics work in the respiratory outbreak because we lost sensitivity while we were treating the neonatal diarrheas. So the vast majority of these kids do not need antibiotics. That should not be the first place we go. Who does need antibiotics? It's the kids that have evidence of systemic infections, and only those kids. So what do we look for in those? It's if they have an abnormal temperature, abnormal being either very low, like I said, below 100, or above 104. Do they have red and mucous membranes, the sclera around their eye? Does that look at what we call injected? Is that really hyperemic, red, inflamed? Then that might be an indication of a systemic infection. Do they have hot joints or a hot umbilicus or an abscessed umbilicus? Evidence of an infection in joints or umbilicus somewhere, that suggests that the bacteria has gotten into the blood, gone to other places. That is a systemically infected animal, and we need to treat it. Or we can have a really high heart rate too. So we use a combination of these characteristics to decide, do we see evidence of systemic infection? but we don't need to treat any of the kids with systemic antibiotics unless they have a systemic infection. We need to be focusing on fluid therapy. I want to point out here that antibiotics given to every kid at birth is not a good solution. It's one that we see fairly widely implemented. And so there's not, I go to a number of farms where they say, well, we manage neonatal diarrhea with just giving every kid at birth a dose of antibiotics orally or injectable. That is probably going to come back and cause you problems in the future. And depending on what drug you're using, it may actually be illegal. So we cannot use fluoroquinolones at all in goats. So products like enrofloxacin, Baytril, which are used pretty heavily for neonatal diarrhea in some of the meat and sheep. Those are illegal in meat and sheep as well, but definitely illegal in dairy goats as well. So there is no legal use of Baytril in a small ruminant. That would all be illegal. But there are some other legal drugs that sometimes people will use to control these diarrheas. And I just want to drive home that those can select for resistance and respiratory pathogens and cause problems. So generally, in my experience, less than 5% of kids need treatment with antibiotics. And it is a management factor. And so now we'll just finish up again with this concept of immunity to pathogen load. So what impacts our pathogen load? The cleanliness of the environment. Contamination accumulates. And so that's why when we see these outbreaks, they tend to snowball on us. You may start the season with very minimal neonatal diarrhea, then you got a few cases, and by the time you get to the end of your kidding season, everything's getting neonatal diarrhea. That's because with each of those animals that's sick, if they're staying in the same environment, the pathogen load, more diarrhea is shed into that environment, and then more pathogen is in that environment. So we want to limit our exposure of older animals to young animals. If you have neonatal diarrhea in a group of animals and you have a newborn kid and you drop it in that pen, they're almost destined to get neonatal diarrhea. So we want to maintain segregation by age. We want to keep those newborn kids away from contaminated environments, away and in a clean environment, and away from animals that potentially have previously had diarrhea. We want to minimize stocking density. Now, I know on a working farm, you can only do so much there, but the more animals we have in an environment, the higher the pathogen load goes. And that means the more antibodies we have to have in order to maintain that balance. So if we're going to have a high pathogen load, we have to have really good colostrum management and antibody levels. And so neonatal housing and cleanliness is important. We talked about E. coli causing disease in that first couple of days. Many times they're infected in the first 24 hours for sure. Everybody recognizes that first 24 hours, our gut is open and absorbing antibodies from the colostrum. Well, during that period of time, whole bacteria can actually cross that gut too. So that first 24 hours of open gut that we talk about for being good for absorbing antibodies is horrible for absorbing bacteria. And so that first 24 hours of cleanliness, putting those kids in a pen that's clean for that first 24 hours is hugely beneficial. And so I just have a picture here. Many of our operations will use cardboard boxes for this type of scenario. Single-use cardboard box. You can see this one's got meconium all over in it on the sides of the box. But these kids go in there for the first 24 hours. It's a single-use box. It costs $1 or $2. You can get these pretty cheap if you're buying them in bulk, if you have a larger operation. And so this, for the first 24 hours, you could put 2 kids in there. If you had twins from a dam, putting them in there in a very clean environment that doesn't have other bacterial contamination for that first 24 hours, even if it's only for that first 24 hours, can have benefit. And then we have the antibody side, that immunity side of this equation. And so we've got to think about the role of colostrum in milk management. What are our bacterial counts in that colostrum and waste milk? I can tell you in dairy systems, it's not infrequent that we're actually colonizing our kids with the bacteria that's causing the diarrhea. And so if we're not, very good in our management of cleaning those milking buckets, cleaning those bottles, cleaning those tubes, and we have a neonatal diarrhea outbreak, that's the first place we want to go and look and see in bacteria. Sure, I want to culture it out of the animal, but I'm almost never leaving that farm without a culture of the milk that's being fed to those kids as it's being fed, and or the colostrum that's being fed, because in many cases our bacteria is actually inoculating them out of the milk or colostrum. And so we got to be focusing on our colostrum management and those bacterial counts. I've got some numbers in here to recognize that colostrum has higher bacterial counts by about tenfold than milk. So colostrum has huge benefits in antibodies, and we got to get colostrum in there. But if you're using raw colostrum, it actually can also be a source of bacteria that can be causing you problems. Colostrum replacers, that's not as much of an issue. The issue on colostrum replacers is often we don't get the same level of antibody, not because we can't, but because it costs too much money to give them colostrum replacer to get as high an antibody level as we might have with natural colostrum. And so when we miss getting that antibody level as high as we can, then that pathogen load has to come down to maintain. So we sometimes see neonatal diarrhea outbreaks when folks switch from natural colostrum to a colostrum replacer. And it's not that the colostrum replacer doesn't work. It's just that the antibody levels we were achieving with our natural colostrum were higher than what we achieve with our colostrum replacer. And so our pathogen load has to be brought down in the environment to maintain that. So failure of passive transfer, critically important. I think y'all have talked about that on other webinars, so I'm not going to dive into that, but I almost never leave. I told you I'm leaving farms with neonatal diarrhea with a fecal sample for diagnostics, with bacterial counts or milk and colostrum to test for bacterial counts. And I'm leaving with data on how good a failure or how good a passive transfer we have in those kids. Because I want to know if we're not getting enough antibody in those kids. That's the problem I got to fix, not the not the antibiotics. So, key take homes from the last hour. When it occurs in the first couple of days of life, it's likely E. coli. Neonatal diarrhea is a management issue. It's a managing pathogen load. It's a management of passive immunity and antibody levels. Clean environment goes a long ways towards improving issues and clean feeding systems. In treatment, we've got to focus on the dehydration and the acid-base status. And the vast majority of kids don't need antibiotics. And that prevention by giving every kid antibiotics at birth is not a sustainable solution. It's going to come back and you're going to regret it in the future when you have respiratory disease or diarrhea that needs treatment that you're not able to treat. And then finally, I don't have it on the slide here, but remember that in these first couple of days, coccidia is not what's driving our diarrhea. So with that, Fred, I think we've got to the end of what I was going to share, and I'm happy to answer some questions.
Very good. We appreciate the information. If you have a question for Dr. Plummer, you can go ahead and put it into the chat. If everybody doesn't flood and talk over each other, you can unmute yourself and ask the question directly. I'll give just a few seconds to get this started.
Yeah, Fred, I see one question in here on how do we measure percent dehydration? And, in people, we visualize the time of tinted pinch and the skin returns to normal after release. Yes, we can use that in ruminants. I'll tell you that ruminants are a bit trickier than humans because they tend to have a lot thicker skin. So, particularly calves or adult cows, that skin can be a centimeter thick. And so skin tints, just the structure of the skin makes skin tints hard. Our most reliable indicators are the depth of the eye ball in the eye socket. And so as they become dehydrated, those are going to recede back. And so if we only have a couple of millimeters of recession, then then you're probably less than 8%. But if that eye, when you look at it, if you're really starting to go like, oh, those eyeballs look sunk in, then you're probably getting up to that area where you're above 8%. We sometimes can use the skin above the eye, the eyelid, for a skin tint as well. And so those are all kind of areas that we would look for assessing dehydration. But really, recession of the eyeball is probably the easiest one to kind of look at. And then I see a question there on leaving kids on dam for colostrum versus removing and feeding. And that's a great question, and it's one I just finishing up an advanced small ruminant production medicine rotation with vet students, and one we discussed this week. And I think in an ideal world, if we have the opportunity to implement a colostrum disease transmission plan that's beneficial. Now, what do I mean by that? We used to call it CAE prevention, and so caprine arthritis encephalitis is passed from mom to the baby through the colostrum. And so we would separate babies at birth. We would heat treat colostrum, or we'd use milk replacer, and then by doing so, we could mitigate CAE transmission in a herd. I think we've now come to realize that actually mitigates a whole bunch of other disease processes that also can be transmitted from mom to baby, including mycoplasmas. Sometimes there's some data around caseous lymphadenitis and contagious abscesses, Johne's disease. And so, from a biosecurity perspective, if we have a way to pull babies off and not have them consuming colostrum and milk from mom, that gives us a tool in our toolbox to control those infectious disease issues. Having said that, things can go really badly if that can't be effectively managed, because either one, we don't have human resources to effectively manage that, or number two, we don't have time to effectively manage that. And so, I'll admit there's been cases where I've told people, yeah, I think putting animals back on mom might be better because you just don't have the time or the energy to effectively accomplish raising those kids on your own. And so we talked about that pathogen load versus immunity. One way to manage more pathogen is more immunity. If I'm having problems managing pathogen load because there's just not enough labor, there's not enough opportunity to clean the environment, to keep the pens clean, to clean the feeding systems, and as much as I can recommend all day long, well, we need to change that. We all know that there's only so much time and so many people that can work. So sometimes increasing immunity by putting an animal back on a dam might mitigate the neonatal diarrhea outbreak, but we may end up having Johne's disease or CAE. And can feeding an electrolyte the first few weeks of life, no matter if the animal's sick or healthy, be beneficial? I think it depends on the product. In general, I don't generally recommend any sort of electrolytes that would be designed to treat a sick animal. Now, they make, there certainly as humans, we drink Gatorades, or Powerade, or whatever your favorite is. You get sweaty, you drink some of that. Those are fairly innocuous types of electrolytes, right? But when we start talking about these products that have alkalizing agents, they're designed to really go in and change that blood pH. I don't think you want to be using those aggressively in an animal that has a normal blood pH. You could potentially consider some other products that just something more like what people would put in water at a show, and we want water in front of these kids, But the fact of the matter is, most of their electrolytes and most of their fluid consumptions coming from the milk and the colostrum. So it's probably way more important that you have a good quality, colostrum replacer, or colostrum and a good quality milk replacer, or milk, whatever you're feeding those kids. Having good quality there, I think, is going to buy you a lot more than free choice electrolytes through the water that may not make a big impact. Fred, you seen any others?
I'm not seeing any others. I've got one here. Early on in your presentation, you had on a slide concern with pressure washing. Can you review that for those folks?
Yeah, sure. And I'm glad you brought that up, because it's one of those things where it's a balance, right? Kind of like the pathogen immunity. Pressure washing can be beneficial in keeping areas clean, calf hutches, pressure washing calf hutches can be a great thing. Cleaning out kidding pens between animals or between years, pressure washing can help reduce pathogen load. Where it goes bad is where there is a pathogen in that environment that can be aerosolized, so that my pressure washer is pulling it up into the air, and then I inhale it while I'm pressure washing it. And so, particularly with Cryptosporidium, we know that can occur. And there's plenty of farms that I have been on that, they'll like, oh, we have a neonatal diarrhea outbreak. And then we went in and we pressure washed the barn, and all the people got diarrhea. And it's like, yep, yeah, anybody that was in that room probably is going to get diarrhea. And so I am a fan of pressure washing, as long as the environment, we can keep the humidity low. We're not, really getting a very hot or moist environment. But with particularly crypto, and really with some other things, aerosol on crypto is important, but you also don't want to be getting splatter in your mouth. So E. coli splatter in your mouth. So wearing a mask, an N95 mask, and some protective clothing, if you're doing that, is probably worthwhile. Is that what you were looking for, Fred, there?
Absolutely. That was where I was hoping you'd go.
Yeah.
I'm not seeing any other questions here.
I see one more here.
Okay.
In an ideal world, what management techniques and strategies would you suggest? So, yeah, that's a big area. In an ideal world, good colostrum management. I think colostrum replacers can be very good. In an ideal world, I would love to have natural colostrum that's appropriately heat treated and doesn't negatively impact the antibodies. And why do I say that? When we look at a colostrum replacer, we're looking at replacing IgG or antibodies. Natural colostrum has way more things in it than that. All these kinds of proteins and other things that are beneficial. But with raw colostrum that you're heat treating, if your heat treatment process isn't going good, you're going to cook those antibodies, and then you have no immunity. And now your balance of pathogen load versus colostrum's problematic. In terms of the hygiene side, I'm a big fan of taking kids when they come off mom, put them in cardboard boxes like I showed there. They come out of cardboard boxes into pens based on age of the animal. And they move up based on their cohort, so they don't continue getting mixed with the older animals. They stay as an age-based cohort and move up. And to the extent that you can have floors and walls and pins that are disinfectable, those are all great, but they all cost money and they all take time to disinfect. So I see one last one here on what's the best treatment plan for E. coli. E. coli, again, fluid therapy, oral fluid therapy, if we can do it early. I didn't mention that with E. coli, there are some options if it's a K99 E. coli. So, we talked about K99 a specific type of E. coli. If it's a K99 E. coli, we do have some options both for vaccination for dams that are used in cows that we can sometimes use in the does, or we do have some products that are produced for calves that actually have antibodies specific to K99 E. coli that you can give orally to kids at birth. It does not work for all E. coli's, but for K99s, those can be beneficial. But aside from that, treatment is based on the acid-base status. E. coli is great producer of that D-lactic acid that we were talking about. So blood acid base status, hydration status, and I only use antibiotics in E. coli kids when I have evidence of systemic disease. I know that runs counter to what a lot of people want to do, but there's data after data after data on the human side and everywhere else that the vast majority of these don't need antibiotics. Now, giving antibiotics sometimes stop the diarrhea? It does, but it has other impacts that may come back to haunt you a year from now. So.
Unless you're seeing a question, I'm going to go ahead and close today's webinar. I want to thank you for the information and the presentation. As always, you present it so even I can understand, and that's certainly appreciated. Thank you again, Dr. Plummer, and for those of you who attended today, we'll look forward to seeing you next quarter.
Thank you. Have a great day.